So I did want to introduce Dr. Wittmann. Like I mentioned, we are so incredibly lucky that she's here to speak with us today. She's a clinical associate professor emeritus at the University of Michigan's Department of Urology. She's a psychotherapist, educator, and researcher. She's an ASEX certified sex therapist and sex therapy supervisor. She's a former associate editor of the Journal of Sexual Medicine. Dr. Wittmann has published research, review, opinion articles, and chapters on sexual issues in cancer and urologic diseases. She's a lead author of the International Guidelines for Sexual Health Care and Prostate Cancer, and her research focuses on using mixed methods to develop and test interventions that support couples' sexual recovery after prostate cancer treatment. She's certainly been a mentor to me and someone whose research I look to often as I'm working in this space. And so really delighted that we'll all get to learn from her together today. So Dr. Wittmann, I will pass it over to you.
Well, thank you very, very much. Let me share my slides now. Let me make sure that I'm in the right spot on them. Okay. Can you see them?
Yes, they're still in, not quite in, there you go. You're perfect.
Okay. It seems that I have raised my hand, which I didn't mean to do, but I think it'll disappear in a while. Okay, so thank you very much for the invitation to come and talk to this group. I'm so thrilled. I've heard so much about Inova, and I know many people who work there. So I'm excited to get to this topic. Here are my disclosures. I want to start out by saying that we don't talk to patients about sexual health enough. This is something so problematic, and we really don't talk to patients about their partners enough. We don't bring it up as a part of oncology care, and we really should. And I think the time has come, and I think more and more people are recognizing that this is really a critically important aspect of patients' quality of life. This is a study that was done by a urologist who at the time was a resident at Johns Hopkins, who is now a young faculty. She went to the Society for Urologic Oncology and put out a survey to find out how routinely people provided preoperative counseling to sexually active men and women who were about to undergo cystectomy. And what she found, you see in this slide, she found that, so this slide shows how much the clinicians did not talk to patients, yellow for female, blue for male patients. You can see that the clinicians did not discuss sexual orientation, partner sexual function, and referral options. And when you look at the comparison between male and female patients, you see that more likely patients were talked to if they were male. When you look at, for example, the potential for nerve-sparing approach, which is so important in prostate cancer, in bladder cancer, they did not speak to female patients at all, hardly. So men were kind of in a better position, and from the point of view of men's health, we are happy about that. But we can just see that the sort of focus on the totality of the patient just was not there. When speaking about couples and their sexual response to cancer diagnosis and treatment, it's really good to look at it from a theoretical point of view to appreciate the biopsychosocial approach to sexuality. In this figure, you can see that there are many impacts that cancer can have on the body, on the psychology, on the relationship, and culture, religion, and society play an important role as well. Cancer can cause, cancer in its treatment can cause hormonal changes in body integrity, scarring, pain, fatigue. And when a man is affected in this way, you can imagine that he begins to feel less comfortable, less confident in his sexual response, uncertain about whether he's going to be able to have pleasure, whether he's going to be able to satisfy his partner. And that may actually make him feel like he doesn't really want to engage in sexual activity. And you can bet that the partner would be aware of the nervousness of the patient, of his inability to function, and that the partner will have her or his own reactions to all of this. We know from research that couples don't generally communicate very effectively about these problems. And some of it has to do with the fact that many couples can have a perfectly good relationship throughout their lifetime without ever talking about it. You know, they communicate by sound and touch, and it's not a problem until there is a dysfunction and then there's a need to talk. And patients have acknowledged that they don't have that skill. Now, because we live in a multicultural context, you know, social, cultural, religious attitudes will not only affect how a sexual dysfunction is experienced, but also what rehabilitation strategies will be acceptable to those patients. We also know that we have gaps in our knowledge about sexual minorities, and those have to do with the fact that we haven't really done enough research. The research has been emerging maybe in the last, I would say, 8 years, largely from Australia, somewhat from the United States. So we have a better sense of the sexual needs of men with prostate cancer in terms of their need for a firmer erection for anal penetration, the importance of the prostate as a sexual organ, the importance of ejaculate. And we need to consider anal comfort and safety after radiation. We also have learned that gay and bisexual men, and certainly people with fluid gender identities or transgender folks, have often non-traditional social supports because many times families have rejected them. There's a little bit of research on African American men and Japanese men. African American men tend to express greater bother about sexual dysfunction than white men, and Japanese men often conflate sexual dysfunction with aging, and so they don't express as much distress. And they may also not regard it as something they would go to a healthcare provider for help. Gender identity issues are so just beginning to be explored that there is really insufficient literature to really understand what their sexual needs are. I was just recently reading an article by a researcher from California who has developed a biopsychosocial model for screening for transgender women with prostate cancer. But the issue of sexual health is very much still under-researched. So how do we think about sexual losses for couples secondary to cancer treatment? So when I started working in prostate cancer, I thought a lot about, what is the process of sexual recovery? And I went to the grief literature because by definition, change in sexual function is a loss unless it's an improvement, which is not the case in cancer care. And so I thought, okay, so every individual and couple, if a person is coupled, has their level of sexual function pre-treatment, and then the cancer comes and treatment comes, and there are side effects. And that means that there are changes in the individual and couple sexual and psychological functioning. And what they arrive at is, and this is what comes from the research literature. So Dr. Parks was a researcher in bereavement at the Tavistock Clinic in London. He coined this phrase, psychosocial transition, which denotes an event that is so life-altering and so profound that there is no going back, that it alters a person's sense of themselves, sense of their emotions, of their body, their position in the world, their relationship, everything. And there's no return to baseline. And I would say for most men, sexual dysfunction after cancer treatment is that there's no return to baseline, but there's no reason to think that there is an inability to have a satisfactory sex life. It's just, it becomes different. What is needed is sexual rehabilitation. It has to be done from a biopsychosocial point of view. And from a psychological point of view, couples engage in grief and mourning and move towards developing a new template for their sexual relationship. So what are the losses that patients experience? So it's usual sexual function, right? Familiar sensation, control over one's body. It can be urinary or fecal incontinence, depending on the cancer, urinary with prostate, fecal with colorectal cancer. Ability to move the body during sex may be compromised, physical and sexual self-image, and familiar sexual interactions with a partner. But what does the partner lose? The partner loses the patient partner's body as they knew it, an unself-conscious sexual partner, a partner who's comfortable initiating sex, a partner who has sexual desire, erectile function, or the lubrication and vaginal, but it can be anal capacity. A patient who is preoccupied with his body and with his own sexual losses and capacity and sex life as they knew it. The grief and mourning tasks are that the patient and the partner have to accept the reality of the loss, experience and allow themselves to experience the pain and emotional aspects of the loss, and adjust to an environment where familiar sexual sensations and activities are missing. Now, the fourth point is a kind of a funny point. Memorializing past sexual functioning has to do with staying connected to who one was as a sexual being and a sexual partner prior to cancer treatment, because it will have an impact on how people recover. People who've had good sexual functioning and good relationship have some optimism about what they can do, and that optimism can be encouraged. People who have had insufficient sexual functioning and maybe a bad sexual relationship have an additional grief to address, and that's the grief of what they never had. That they never really were able to achieve a good sexual relationship with a partner, and now they have this additional loss. So they have a lot more to work on when they move forward in their sexual recovery. We have studied some potential barriers to sexual recovery after cancer. One of them is unrealistic expectations of outcomes. And I'll speak to that a little bit later. Dislike of unspontaneous sex, talk about that a little bit later as well. And aversion to using sexual aids. Those are the kinds of things that really interfere with people's ability to move forward, and they can be conceptualized as expressions of grief and mourning. As patients move with their partners towards new sexual interactions once they've healed from their treatment, they will find that grief becomes a part of every sexual interaction, as intrusive thoughts will make them anxious and worried about whether they're going to be able to have pleasure, whether they're going to be able to provide their partner with pleasure, whether they're going to be able to have an orgasm. And of course, the partner is worried about the same thing. And so these intrusive thoughts diminish the availability of dopamine to focus on pleasure. And so they really have to work very hard to stay focused. And they may have to interrupt, talk about what's going on, reassure themselves and each other, and move. Once they move to orgasm, if they can get there, or some pleasure, that is very encouraging. And that can give them some confidence about repeating the activity. But that is an experience that people don't necessarily anticipate, and it can act as a barrier and as a stimulant for avoiding sexual activity as a couple. Now, interesting, as we were kind of working on the development of this model of sexual recovery, there was a article that came out about breast cancer patients that added another dimensions to this, and I thought it was worth including, because what this article talks about is the way in which cancer patients sometimes feel that their grief is not warranted, not legitimate, not reasonable, because they've just had cancer treatment. This is a life-saving treatment. Perhaps it was quite successful. And how can they ask for more? And frankly, clinicians often have that attitude as well. When patients come to them with questions about sex, they will say, maybe not to the patient, but as an aside to a colleague, you know, what can I do for them? I already worked on saving their life and I was quite successful. What can I do with that? But I think that mostly comes not so much because clinicians don't want to help. It's because they really don't know what to do with that question. You know, they don't know much about sexuality and they don't know what the resources are. So they don't really want to touch this subject. So disenfranchised grief is the concept that Pillai Friedman and Ashline coined for cancer patients who may not feel entitled to this. And we have to be very careful to be sure that patients do feel entitled to ask these questions. So we tested our model of sexual recovery for couples by interviewing 20 couples before and after surgery for prostate cancer. You can see this is very similar to what I showed you before. What's new here is, so we wanted to see whether there were actually psychosocial sexual losses and whether patients and partners were grieving. And we found that that was true. But what we found that was new was that they actually began that grief process before treatment. They were anticipating these losses and they started to grieve early. They also experienced the grief as ambiguous because they didn't know how long any kind of recovery would last and how much sexual functioning the man would recover. And that made the grief more ongoing because they really didn't know when the ending was going to come and what they were going to get. We also found that there were more helpful or more unhelpful ways of coping, and that was helpful in sort of designing interventions. We found that the factors that contribute to a more or less successful couple sexual recovery were the following. Positive coping was characterized by the couple's ability to share normal grief and mourning, a regular engagement in sexual activity, the acceptance of sexual losses, the willingness to use sexual aids, and the positive interest in sex of the partner, regardless of menopause, you know, that was female partners. The self-defeating coping was characterized by inability to share the grief and mourning, no or infrequent sexual activity, relationship problems, stressors, inflexible sexualities, couldn't learn new things, and partners low or no interest in sex regardless of menopause. So most of our patients, except for one couple, were heterosexual, and that's why you see the regardless of menopause. So it was interesting to see that the psychological work was really important. And we know from previous literature that men tended not to use sexual aids without some counseling or the participation of a partner. So at the same time as we were developing and testing this model, there was research being done in Canada where they looked at couples' ability to recover sexual intimacy, and they were looking at two dimensions where patients and partners valued physical pleasure and relational intimacy. And they found that the couples who valued relational intimacy were more likely to be successful, meaning that if sex was the only glue that kept the couple together, once they lost it, they didn't really have any other methodology for staying close. But if they have that physical and emotional intimacy, it was much more helpful. And similarly to us, they found that acceptance, flexibility, and persistence were factors that helped couples retain their sexual relationship. So I think we were basically all finding the same things: persistence, acceptance, ability to grieve, and willingness to be emotionally vulnerable and intimate. So let's talk about couple sexual recovery after treatment. So some years ago, we summarized the research on interventions on couple sexual recovery. Most of the research, honestly, is done on prostate cancer, so I have to make that caveat. There are 4 pilot studies of couples where there was an ability of improvement of sexual function in some of these studies. In one study, partners were more accepting of the man's erectile dysfunction as more accepting of the fact that a man could have a satisfying sex life without erectile function. And in one was a preoperative expectation, preoperative education, which led to a greater acceptance to couples being willing to realize that sexual function would be effective. There were 4 randomized controlled trials. At least in 2 of them, the number of patients was quite small. The main finding of these trials is that the involvement of a partner helps with the acceptance of proerectile aids. Counseling also helps, and that online intervention can be just as good as an in-person intervention, which I actually don't believe is totally true. We also, with funding from the Movember Foundation, did a multi-site study of couple sexual recovery intervention. It was tailored to treatment type, sexual orientation, and partnership. And we found that the intervention helped couples engage early in penetrative and non-penetrative sexual activity. We also found that the partner scoping and ability to grieve the loss of the man's sexual function affected both the patient's and the partner's satisfaction with sex life. So that highlights the importance of looking at couples when you consider the cancer experience, which of course all of you in the audience already know, but it's always good to demonstrate that empirically. That intervention is now on the website of the Rogel Cancer Center at the University of Michigan. It's also on the website of the Winship Cancer Center at Emory and can be available to anybody throughout the United States to access. And here's the website, sexualrecoveryafterprostatecancer.org. So how do couples come to any kind of sexual health treatment unless they are asking for it specifically, or unless it's, well, even if they ask? So one of the things that I learned in my practice is that I have been a therapist and a couples therapist for a long time before I even got into sexual health and into sexual health in cancer. And the difference is that when you are a therapist in an institution or in a private practice, people come to you because they want help as couples. They know they have problems. They come to you for help. They realize it's going to be work. In the cancer context, people might never have been looking for a couples therapist. They may have couples problems. They may have sexual problems. They were never really looking for it. But now they have cancer, they have sexual dysfunction, and somebody tells them, well, maybe you could get some help, you could get some rehabilitation. And so they come to you, or in our program, we are embedded. And they say, okay, we'll take advantage of that. Great. They're unprepared for the work they're going to have to do. They're unprepared for the way that their relationship is going to be analyzed by a therapist. They're unprepared to take on the hard work of sexual recovery. And that is something that we as clinicians have to be aware of and support them through and educate them about what happens in therapy to be able to accomplish their goals. Oftentimes people think of sex therapy as kind of a magical, fun thing to do. And it's not that after cancer. It's hard work. Before any kind of therapy can take place, the first intervention, I think that is very important, is pre-treatment education about the side effects of cancer treatment, about the sexual side effects. So I told you earlier that sometimes people have unrealistic expectations. We did a study, more than 10 years ago of patients' expectations of the urinary, bowel, hormonal, and sexual outcomes 1 year after treatment, and found that 44% of those patients expected that the urinary incontinence and erectile function was going to be better than what actually they were able to attain. Now, I don't know what kind of education those patients had, whether they had realistic education, but they certainly expected more than what they got. So they had to deal with disappointment. Interestingly and peculiarly, 70% of those patients expected erections to improve after surgery. Now, that's a very odd expectation. We hypothesize that this was at the time where people were starting to use robots, and patients attributed sort of miracle qualities to robotic surgery. So we thought that might have been the reason. But as a result of these findings, we instituted preoperative education and found that when patients were taught to anticipate sexual problems, 73% of them expected erections to be changed after surgery, and that was true for partners as well. And only 4% expected erections to be better after surgery. So some people you just can't convince, but it was better than 17%. We also educate now patients about anticipating the emotional effects, the loss and grief. And they tell us afterwards in clinic, after treatment, that this is helpful because they don't get upset when they get distracted during the sexual activity by their feelings. They know that that is what's supposed to be happening. We also tell patients that over time, if they stay sexually engaged, they will learn how their bodies function, how their relationship can be effective, and they begin to feel a sense of competency. They have competency about using sexual aids, and they begin to feel much more positive and optimistic, and that is what's critical. We have found that couples that sustain the work also end up being emotionally closer than they used to be because they have to do all that communicating. And they find that to be a very positive ingredient of sexual recovery. Now, I'm not going to say that anybody would recommend cancer treatment, but that is an element that is a positive one for these couples. So as clinicians who see couples, we have to kind of have a combined toolbox as couple therapists and sex therapists. So what are the couple therapist skills? So one of them is to recognize that the couple is the client. It's not the patient, the cancer patient. It's also not the partner. No matter who comes to ask for treatment, if you see a couple, the couple is the client, because taking sides would really defeat the work. So it's important to understand couple dynamics. It's also important to understand individual development, to see how individual members of a couple came to interact in the couple context the way that they do. It's also important to have a knowledge of mental health conditions and diagnosis for a differential diagnosis. To give an example, you may find that, let's say, somebody was just treated for cancer and now this person is gone. Suddenly the guy is having affairs and he's just really bailed out on the relationship, and you think, oh, you're treating infidelity. You may be treating the beginning of a hypomanic condition. You have to really understand what you're seeing. One of the things that I have found is having a sense of humor can be really helpful. Couples really respond to that, not at the beginning when they're anxious, but once they sort of dealing with a sexual recovery, humor is very, very helpful, especially when you have to give them some hard feedback. Using humor can be very helpful because they realize that you're on their side, even though you're giving them hard feedback. Now, what skills do you have to have as a sex therapist? You have to have the knowledge of biopsychosocial sexuality, sexual dysfunctions and treatments. You have to have a knowledge of the impact of chronic conditions and substance abuse and trauma on sexuality, and you have to have a knowledge of LGBTQ sexual practices and their issues in society. So going towards a sexual health assessment, it's important to learn about the patient's and partner's baseline sexual function and current sexual function, their understanding of the impact of cancer and its treatment on their sexuality, their physical symptoms that may interfere, their grief response, and their attitudes towards sexual changes. Because oftentimes partners, for example, try to be extremely supportive and helpful. There comes a time that they may feel exhausted by having that role. That has to be acknowledged that can happen. I have had a couple where the man was dealing with erectile dysfunction, and when it came to teaching sexual aids, the partner said, I'm getting out of here. I'm not listening to this. He's always been, sex has always been about him. Now it's going to be only more about him. So they were referred to couples therapy and had to work on the pre-existing issues before they could successfully engage in sexual recovery. Sex therapists have to know about comorbidities, substance abuse, and potential external stressors and cultural framework. When one wants to go deeper and really truly, so much of this is helpful for initial education, initial untangling of sort of what's going on for the patient and for the partner. But to really do a true sex therapy, one has to learn about the history of the relationship. One has to learn about how patient and partner communicate, how they communicate about sex, and whether they have any pre-existing sexual problems. I generally also take an individual history of the patient and the partner to find out about early attitudes to sex that can make rehabilitation difficult, early negative relationship experiences, family history of loss and trauma that can have an impact, and history of mental illness. The culture is also, and religion is also important. I've had a number of patients from other cultures who had specific religious attitudes or practices about early sexual education or lack of, and exposure to the opposite sex, etc. All of this was important in formulating my understanding of the patient's and the partner's issues. And then after that assessment, it's important to give feedback. Whatever my understanding as a sex therapist is, I give as feedback. And I do it from a biopsychosocial point of view. The biological issues are what biological changes have happened that may or may not change over time and that affect sexual functioning and the sexual relationship. So if somebody's going to have persistent erectile dysfunction, that's going to be an issue that has to be dealt with on its own, through physical rehabilitation, but there's not going to be a return of spontaneous erection. What are the psychological issues of the individuals within the couple? Like I will notice that the patient, when he's feeling uncertain, lacking in confidence, he'll withdraw and he will isolate himself, which is going to work exactly against his goal to be more intimate with his partner. I will not point out to the partner that when he or she has any kinds of concerns, he or she provokes a fight. And that fight doesn't necessarily lead to the kind of closeness that the partner wants. And I talk to them about what I see as a past dynamic in resolving problems, in being able to talk, in being able to come together to work as a team. Because sometimes often couples don't realize the dynamic that they might have. I think sometimes, let's say, if I see that there's a member of the couple that's always blaming the other one, I have to point that out to them. Those are the kinds of things that are going to come back during the sex therapy work, and I have to be able to refer back to it. We also talk about the impact of culture and what's acceptable or not. What I think of in this context is that the feedback is the beginning of shared reality. So when I give feedback, the patient and partner will feed back to me what they agree with, what they don't agree with, and we negotiate a common understanding. We have to have that to be able to do the work. I've worked with enough couples where they blame each other for everything, where you don't have a shared reality. He sees the problem in her, she sees the problem in him. It doesn't have to be a heterosexual couple. You don't have shared reality, you have nothing to work with. So the biopsychosocial formulation is the beginning of a shared reality between the couple and the therapist, and can be reached to when some of these issues come up in the process of treatment and say, remember when we talked about that? I remember what we said then. I remember this is something that you agreed you would work on. Now, there are some specific issues that come up for patients and partners that are specific to them. So partners might be made aware of the fact that if they want to reassure the patient that the sexual dysfunction based on the cancer treatment is not going to interfere with their desire to be sexually active with them, that's fine, but it only goes so far. The patient has to be given a room to mourn his loss of his body image as he knew it. It's not just about sex. It's also about how the man is used to seeing himself. He's used to seeing himself with an erection throughout his life. If he now loses it, he has to be given the room to grieve. And then the partner also has to be aware that if the patient has low desire or problems with erections, it's not because he's not attracted to the partner. And this has been true of both male and female partner, that they relied throughout their sexual relationship without realizing it on the erection or on the partner's desire to feel reassured that they are attractive and that they are desirable. And now they don't have that. So now they have to develop more of a language communication about this and not misinterpret what this means. Patients may need to be reminded that they still be good lovers, no matter what the sexual dysfunction, and that they will not be found unattractive, either by their existing partner or a partner that they will meet. That sex is not just about sexual function. So in sex therapy or in sexual health support, we definitely work on grief work. We talk a lot about provoked versus spontaneous arousal. So everybody glorifies spontaneous arousal, and people who've had children know that often spontaneous sex often goes out of the window when you have young children. And there's often resistance to the idea that you start with stimulation that provokes desire, that provokes arousal, and then you sort of can continue towards sexual activity. I was just recently at a conference of the Society for Sex Therapy and Research, and somebody brought a study that they had done with young couples about provoked versus spontaneous arousal. And of course, everybody preferred spontaneous arousal, but when it came to satisfaction at the end of the sexual activity, it was the same regardless of how the sexual activity started. So that's really nice evidence for the fact that you may not have spontaneous arousal, but arousal of any kind is a good thing. We often do education about the relationship between the cancer treatment and side effects, talk about realistic expectations, communication, and then work on progressive return to sexual interactions through sensual touch. Sometimes people really need the reassurance to do the sensual activity before engaging in sex because they're too insecure about their functioning. And many times people kind of rediscover pleasure spots on their bodies that they'd forgotten about or they didn't know they have. And I've had the experience of sometimes seeing, for example, a man who now has erectile dysfunction, who is working on sensate focus. Suddenly he realizes that he's such a good provider of sensual touch and that his partner really loves it. And it makes him feel so good and competent and strong and masculine. And so there are many benefits to sensate focus exercises, one of which is that it expands ultimately sexual repertoire because it can become a really nice part of foreplay. There's a lot of counseling regarding sexual aids, an expansion of sexual repertoire. Some discussion has been had, in the research literature about the importance of people being able to be flexible when thinking about what sex means. And this is often a discussion with couples engaging in non-penetrative sex, including oral sex, manual stimulation, the use of vibrators. Sometimes people start when they are like 17 or 15 with non-penetrative sex and do everything else. But once they have a partner and once they are comfortable with each other, foreplay is very minimal and they do not do those things anymore. And in the context of cancer and working on sexual recovery, it becomes important to be willing to do that. In gay couples, there's the issue of potential role changes. If one person has been, let's say, the penetrative partner and now has problems with erections, is he willing to try being the receptive partner? And there's at least one study that suggests that some couples do that and other couples don't. And it's just an option that can be discussed and people decide on their own what they want to do. One of the benefits of sex therapy is developing language for sexual problem solving. And of course, sex therapists have to be sensitive to diverse groups from a cultural, ethnic, or LGBTI point of view. Who's going to be successful? Couples who put in the work, and it is work. People have dropped out because they don't want to do the work, but people who do see the benefit. Couples who have a good relational capacity, which means that they can care about the other person, they're willing to look at themselves as they do in the work to see what barriers they might be bringing to it. Those couples generally will do well. Couples that are willing to prioritize sex, even though it's sometimes arduous, and are flexible in pursuing sexual pleasure, those couples will do well. I don't think I have to tell this to this group, but multidisciplinary approach is really important when it comes to sex. Every cancer patient has their cancer doctor. Many have advanced practice providers and nurses. Those are very good about, those clinicians are very good at teaching sexual aids use. They address health in general and lifestyle modifications, all of which is really important for sexual functioning. Then there are, of course, sexual health experts who have training in sex therapy. There are mental health experts who are helpful with depression and anxiety. Physical therapists are hugely important for incontinence, freeing nerves from being entrapped, helping with pain reduction and bowel leakage. So physical therapists are a very important component of the team. Endocrinologists can evaluate and manage hormones after treatment as is possible. And for patients who are in the fertility range of their life cycle, having a fertility expert will be helpful before and sometimes after treatment. I do want to mention that at the University of Michigan, we have a survivorship program embedded in oncology care. So our patients, when they get scheduled for surgery, automatically scheduled for physical therapy and for an evaluation at 6 weeks with a sex therapist. And after that, care is individualized, but all these patients automatically go, and we've done some follow-up, well, not follow-up, some research on patients and partners who tell us that if it wasn't embedded, they probably wouldn't have come for sexual health help. So embedding a sexual health in oncology care is the most effective way of getting patients to take advantage of it and their partners. So not everybody has to be a sex therapist, right? The Plicit model helps us identify methodologies for helping patients get the care that they need. So any clinician can bring up sexual concerns, and in fact, oncologists are the ones, or urologists or radiation oncologists, are the ones who are in the best position to talk about, to bring it up without having to do much follow-up about what to do about it, as long as they have resources at their fingertips. And it normalizes it for the patient and is a very important gateway to sexual recovery. Clinicians of all kinds can provide limited information, the connection between the sexual side effects and the cancer treatment, some idea about what the functional recovery will look like, understanding about the emotional reaction and available rehabilitation. When it comes to specific suggestions, the mental health people can provide the emotional support, and nurses can be experts at teaching sexual aids. Of course, there's always a little bit of overlap in all of this. And then intensive therapy should be really done by people who are qualified in sex therapy, but who also have an understanding of the impact of cancer on sexuality. And sex therapists can be found in every state by going to the website of the American Association of Sex Educators, Counselors, and Therapists. I wanted to list some resources. The Movember Foundation has a website that patients can go to get information about sexual recovery. We also, in the past few years, published in 2022 guidelines for sexual health care. Is very much done from biopsychosocial perspective. It has a sort of theoretical orientation and has 6 principles that guided. The first principle, most important principle, is that clinicians are the ones who have the responsibility to bring up sexual issues for prostate cancer patients. Everything else flows from there. The guidelines in full, so that was what I just showed you was the article that summarizes the guidelines. The full guidelines are on the website of the Movember Foundation. There's a one-pager that summarizes the guidelines and points out which statements of the guidelines are involved in pre-treatment, post-treatment care, and assessment. And the American Cancer Society, of course, has information as well. And then this is the website of the American Association of Sexuality Educators, Counselors, and Therapists, where you can find your state and a therapist wherever they are. If anybody in this group is interested in education that will enable them to provide sexual health counseling or sexual health therapy, the University of Michigan has a certificate program that satisfies the academic requirement of the certification by ASEC, the association that I've just told you. it's an online program that can be done from your office or your living room. Some of the people in the audience have already done that program, and I think it's quite effective. And that's all I had to bring you today. Thank you, and I'll be happy to take any questions.
Great. Thank you, Dr. Wittmann. That was an exceptional presentation with lots of really good information. We do have a number of patients on the call, so I'm sure that they're going to have a lot of good questions just about how this may impact them and their care and resources that are available to them, and also some clinicians too. There was a question that came in about the name of the University of Michigan program that you mentioned, sexual recovery after prostate cancer, or just a little bit more about that program and what it's called.
Okay, so you mean if the person means, I think the online program, is that correct?
I believe so. It came
Yeah.
in.
Okay. So it's a program that consists of 6 sessions. Starts before treatment and goes to 6 months after treatment. It's timed to the sort of trajectory of the recovery, but patients and partners can look at all those sessions at once if they want to. So each session includes a video of a patient or patient and partner then who've had this experience. Then there's educational content. Then there is an activity, some suggested activities, and then there's a question about any concerns that people have. And in the research, we and the couples can compare what each other's concerns are and have a discussion about it. In the research, we sent recommendations for the concerns. You know, now that this is online, there's really nobody tending it, so people just get to discuss their concerns. One of the modules, one of the sessions is how to talk to your healthcare provider about your sexual concerns about prostate cancer. That includes a checklist of the kinds of questions that a person can go and ask of their provider. So it's quite comprehensive. It has content on, like, it teaches people how to do sensitive focus exercise. It has all the information about pro-erectile aids. It has things on loss and grief. You know, it has for heterosexual couples. It has issues. It has information about what to do about menopause for a menopausal partner. You know, it's information for gay couples. So it has quite a lot of information. And I don't know if people want my slides, I can send the brochure to you, actually, Jennifer. If you like, I can send you the brochure and then you can distribute it.
That would be great. Because someone's asking if there's a website for the program. I was going to try to pull it up if there is one.
Well, you would have to go to the University of Michigan Rogel Cancer Center and type in survivorship.
Okay, great. I'll do that.
Yeah, but I will send you the brochure and you can just send it to
Perfect.
whoever's interested.
Good. Somebody asked if there are any resources for patients who do not currently have a partner but need help in initiating a relationship after prostate cancer. So if you could talk about resources or even some suggestions that you've used clinically when working with patients, I think that would be wonderful.
Yes. So I don't know that there are any resources that are specific to this, quite honestly. I think that any counselor can address this if somebody wants to talk to a counselor about it, because there will be the issue of disclosing prostate cancer and then disclosing the sexual dysfunction and the need to use sexual aids. You know, when I've talked to patients about this, basically I say, sometimes people feel like when they go on their first date, they have to disclose everything because they sort of want to prevent a later rejection. And I always say to them, you know, get to know the person first to see whether they are the kind of person that is empathic, that is supportive, that is interested in you as a person. et cetera, and then disclose the prostate cancer first and see what reaction you get. If you get a really positive reaction, the person says, tell me more about it, I'm really interested. Gradually get to the sexual issues, because anybody with any kind of problem or disability has to be partnered with an empathic, supportive partner. And so people shouldn't just blurt out of anxiety all their issues to a new person that they meet. They also don't have to continue going out with anyone if they find that that person's really not that sensitive or thoughtful, and don't have to disclose anything to that person. Just move on based on what they know about who they're dating.
That's great information. We don't ever tell anyone everything on that first date.
Yes.
I've had a lot of patients, because there's so much online dating, that they oftentimes will practice. So they may go out with someone that they're not super interested in, and they practice telling their story, or maybe they'll tell someone on the first date, but someone on the 5th date, and they play around with it a little bit. Which
that's a great idea.
Really scary, but it can take some time to find your voice.
Yes, and really be very, I would say to a person, be selective. And don't feel like you have an obligation, because you don't.
Do folks have any other questions for Dr. Wittmann while we have her here? Okay. I don't see any popping up, but thank you so much. We will be sure to get out some information and resources that she talked about today, and certainly hope that you'll join us for other conversations in this series. But really appreciate everyone joining tonight. Dr. Wittmann, really appreciate all your information and knowledge that you shared, and we hope that everyone has a great evening.
Thank you.